Okay, so welcome everybody. Today we're going to talk about, I think, what is a very, very important topic. In particular, uh, from now onwards, we are really going to look at what I would say are strategies for intervention when it comes to using the lung ultrasound. And an important aspect of that is when you do that is that you use all interventions in a manner that is safe. I would say evidence-based and following a very structured protocol. Now, today's session will be a little bit interactive. We're going to have a workshop. So we're going to have a case-based discussion first, and we're going to nominate a few of you to kind of talk through a case that I'm going to show you. We're then going to focus a little bit on lung recruitment physiology and the importance of heart-lung interaction, followed by really what evidence there is currently for the use of lung ultrasound in the process of lung recruitment, but then talk about the neonatal protocols and how we implement them, as well as patterns of lung ultrasound that correlate with recruitment. As a first, I think what I'd like to say is that when we're using lung ultrasound for any kind of diagnostic process, it's really important that we're sticking to, I would say, a kind of an approach that involves clinical correlation. And for any baby who, say, starts desaturating or having low saturations on the ventilator, it's really, really important from our perspective that we kind of follow a structured approach. And the common approaches involve an ABC approach, where really what you'd like to make sure is that your tube or any kind of respiratory support that's supporting the baby is actually working effectively, is in the right place, that that system is not dysfunctional. You don't have a blocked ET tube, or you don't have CPAP that's dislodged from the baby's nose. You've got good mask seal. But more importantly, then there are pathologies that you can diagnose by chest X-ray and lung ultrasound that become quite important. And that might be a pneumothorax, it might be an evolving pneumonia, it might be a collapse consolidation, it might be something that's related to the underlying pathology that's causing respiratory distress in the baby. But it may well be that you have pathology outside of that, maybe cardiac, maybe neurological, may be related to sepsis that is causing problems with acute desaturation. And that's why clinical correlation is very important, but that usually should be followed up by very careful clinical assessment. And in particular, what I'd say is that involves an examination, and any structured approach would start with, I would say, what kind of airway and breathing support you're on, the ET tube, but really a head to toe kind of an approach, which looks at the heart and lung in particular. Gases and trend analysis of observations. We use histograms in our unit. All of them kind of culminate in us making sure that we've gone through what I call as the DOPES algorithm. But eventually you're going to use chest X-ray, lung ultrasound, as one of the kind of investigation modalities in this situation to try and make a diagnosis, especially if you think there is a respiratory cause. We'll talk about airway-based ultrasound to kind of look at where the ET tube might be. When you use that assessment approach, I would say you really, from your perspective, want to have a structured protocol of not just how you're going to approach the baby. And a good example is a baby who might be acutely desaturating on the ventilator, but actually what you want to do is make sure that you've got the ability to make and manage interventions in real time alongside that. So if you have a baby whose saturations are dropping quite quickly, you want to kind of intervene before that baby becomes so hypoxic that he starts becoming bradycardic. So really, a lot of the clinical management will happen simultaneously. Now, I'm going to talk to you about a clinical approach, and the clinical approach that we kind of use, where I've kind of trained in Southampton, something that I'm trying to set up in the Corniche as well, is a concept called the pit stop approach. And why is that important? That's important because if you're using any diagnostic protocol, whether that's chest X-ray or lung ultrasound, you sometimes have to do that in a baby while they're clinically deteriorating. Now, naturally, what you don't want to interfere with is processes that are keeping that baby physiologically stable, that is interfering with ventilation. But at times, you might have to do this ultrasound while this baby is actually being resuscitated. And there are significant challenges around doing that. Now, from our perspective, what we normally do in situations like that is we have a four-member team, one of whom is in charge of the airway and is ensuring effective ventilation, movement of the chest. If it's come down to the point where you're really needing to do compressions, then really what you'd be doing with this four-member team is probably giving compressions from the head end to allow somebody to be able to do an ultrasound, usually from the subcostal view to start off with, or the apical view. And really, it is really important in those circumstances that you do not actually interfere with the effectiveness of resuscitation. I'd say during the phase of deterioration, again, you have to be really careful. Small things like ultrasound compression of the chest can actually add to deterioration because you'll interfere with just recruitment of the lungs. And it's really, really important that if you're doing an ultrasound, and Nadia will talk about that when she takes the safer approach, that you really start based on your clinical history with the point of interest. And a good example is if I've got a right-sided pneumothorax, because I suspect there's reduced air entry and I transluminate on that side, I will start my lung ultrasound there because that is going to make my diagnosis. But it should be a comprehensive scan that is done so that you're doing both right and left sides. Now, in a pneumothorax, an anterolateral scan may be sufficient, but clearly, if you don't find something that explains that in an anterolateral scan, then what you have to do is you have to go for a comprehensive scan. And once you've done that and you've come to your diagnosis, that's when you make management decisions. Now, naturally, if that is going to be a needle thoracentesis in a baby who has a tension pneumothorax, it's almost always in situations like that going to help, but you might need to put a pigtail in. And that's where I would say having a structured approach, a four-member team where somebody is managing the airway while you're doing needle thoracentesis with other members of the team, then preparing for chest drains becomes quite important because you want to do this in parallel as opposed to trying to do this sequentially. It is really risky in this situation if you decide to do an intervention at a time because it'll just prolong, I would say, therapeutic management in this situation. How you organize yourself in this situation is also very important. How you keep your machine. Really, machines are really bulky, and trying to keep a machine on the left or right side of the baby can make a big difference to how you're going to do imaging. We simulate for this, and in our face-to-face course that we're running next in June, we really talk through participants and get them to actually focus on how they're going to organize themselves, the ultrasound machine, to actually produce the best images with the ability to be able to not compromise resuscitation. That often means compressions from the top end. If you're coming to the point where you're doing this in delivery suite after the baby's born, you're going to need UVC access from the bottom. And again, for a person who's right-handed, doing a left-handed procedure can be incredibly challenging. It needs a lot of human factors, a lot of teamwork, and a lot of good communication to ensure that you can do things appropriately. I'm just giving you a flavor here of, how difficult it can be in these situations. I'm going to now go to a case, and what we're going to do is we're going to uh, just admitting a few of our colleagues. So for those of you who've joined us late, don't worry, you haven't missed anything because we're just starting out. But any volunteers for this case?
Yes, Dr. Alu, I
Okay, I've
can
got
participate.
Surjit. Anybody who wants to help Surjit? And Dr. Doolan, are you happy to give Surjit a hand?
Yeah, yeah, absolutely.
Fantastic. Okay. So what we're going to do is we're going to look at this case, and in particular, we're going to focus a little bit on some history, some images. We're going to talk a little bit about the quality of the images and how you feel they are. But really, what we're then going to do is mentally model and think about pathology and how we might want to intervene. So I have a preterm baby who's 25 weeks gestation. The baby was one of twins. The other twin died at delivery because there was quite significant prolonged rupture of membranes. Uh, this was basically rupture of membranes affecting one of the twins. The twin that died at delivery basically was resuscitated and developed bilateral pneumothoraces and passed away in delivery suite. This baby and both babies, the mother had antenatal steroids and magnesium sulfate. Eventually, it was an elective cesarean because the other twin was about 500 grams severely IUGR, and that's the twin that passed away. This twin was intubated, ventilated, did well, had 2 doses of surfactant, and has now been ventilated for 2 weeks. Naturally, We're not entirely sure which of the twins had rupture of membranes, so it's there in the history. The initial management of conventional ventilation with a dose of surfactant in delivery suite was followed up by another dose of surfactant 24 hours later. And the baby's kind of now been evolving into a picture of needing quite high ventilation. So volume guarantee at 6 mils per kilo, pressures anywhere between 24 to 28 in order to achieve kind of that tidal volume. We've been in about 60%. And, the baby's kind of got a chest x-ray picture of, I would say, evolving lung disease. No focal pneumonia, no focal patchiness, no air trapping, no PIE, just evolving lung disease. And really, the discussion that we're having after having completed antibiotics in the first week of life is whether this baby may be heading towards steroids. Okay, so that's kind of background. Any questions?
Have we done any blood work today? Any
Yep.
sepsis?
Beautiful. So at the moment, based on this history, we completed a week of antibiotics in the kind of first week of life. The baby's been stable. We've kind of been doing TPN bloods and CRPs routinely, and the CRP this morning was 2. White cell count was normal. We've had ET secretions sent in preparation for starting steroids, possibly, after 2 weeks of age, and there's no growth at 48 hours. No significant concerns with regards to sepsis at this point on the morning
And
ward
then
round.
we've done an echo, any PDA, any PPHN?
Okay, so we don't have any heart murmurs. Blood pressures are stable. We don't have a pre and postductal saturation difference. We haven't done an echo at the moment because we're not clinically suspecting a PDA. But it does remain an option, obviously. Anything else?
Have we done a chest X-ray?
Yep, we've done a chest X-ray just 24 hours back. Uniform appearance of both lungs, well recruited, 9 posterior spaces. Diffuse kind of, I would say RDS kind of an appearance. No focal collapse, no focal consolidation. The baby's gases are acceptable. pH is 7.22 to 7.26. We're running kind of CO2s in the range of 50 to 60. So kind of a permissive hypercapnia at this stage. The baby's got good chest wall movement in the morning ward round. No blood pressure problems.
Okay, so what about the lung ultrasound?
So we haven't necessarily needed one so far.
Okay.
Okay, so we don't have any background needs for doing one because the chest X-ray is okay. Anything else? So if I say to you that 3 o'clock in the morning now, I've received a call and the basic problem is our saturations are deteriorating. For the last 20 minutes, our sats have kind of been 78 to 80%. We are currently on VG at 6 mils per kilo, needing pressures of 30. And really, we're not achieving that volume. The alarm kind of is going off to say that we're not achieving those tidal volumes. We've gone into an FiO2 of 100%. Baby's nursed supine. They've done a kind of a dope assessment and they're happy that the tube is in situ. They're happy it's not obstructed because you have good chest wall movement. Air entry is a little bit reduced on the right side. And they did a gas just 20 minutes back. And this was the gas pH at 7.2, CO2 of 64.
Have they transilluminated
Yeah,
the
so
chest?
transillumination is negative.
Yeah, I would have thought of pneumothorax, but like as the air entry is also less, but as the X-ray doesn't show pneumothorax at
The
that
X-ray was
time,
done 24 hours back.
okay. So I would like to get one X-ray done immediately,
Okay.
and I would expect pneumothorax otherwise, or maybe because there are chances of sepsis, as there was PROM. So I can even think of some like atelectasis or some pneumonia or
Okay. So great. So you're kind of thinking of differentials in this situation. So at least clinically, even with transillumination, a small pneumothorax cannot be completely excluded. There's definitely the possibility of, this baby's been tubed for 2 weeks off antibiotics, sepsis, pneumonia. Well, with evolving lung disease, the tube might be down the right main bronchus. The tube is at good position at the lips. It's 6 for a 770 grammer, which is where it was on the previous X-ray, and that was above the carina. So it's going to take 30 minutes to do a chest X-ray. So would you like to do an ultrasound?
Yes, I
Yeah.
would like to do because it will hardly take 2 to 3 minutes to do that.
Okay, so we're going to go sequentially. So this is the right side.
Yeah.
So you can see the ribs, you can see bat wing sign, you can see movement of the pleura. There's a B profile with some consolidation subpleura.
Hmm.
Doesn't look like what I'd expect to see if there was a pneumothorax there on that view.
Okay, great. What do we think about sliding?
The lung sliding otherwise looks
Yeah.
normal to me. But there is disruption of pleura at few places, and there is subpleural consolidation.
Fair point.
Um,
Okay, so because there's lung sliding, this is really, really important. Now, this baby is not fighting the ventilator. He's sedated well. He's on morphine. Uh, we also use midazolam over here, which I'm not very fond of. So the baby's well sedated, and there's sliding on the ventilator. So what does that say to you about the ET tube?
Well, I think the ET tube is in.
Yeah,
Yeah.
yeah. So just for everybody, the ET tube, if you've got sliding of both the right and the left lungs, provided the baby's not spontaneously breathing, it's an indirect marker that the tube should be in situ. Now, naturally, it's very much like everything else. It needs to be clinically correlated. You need to look at loops on the ventilator, but just be very careful. The reason I'm using this as a teaching point is if a baby is spontaneously breathing, your ET tube could still be dislodged and you will still get sliding. So just be very, very careful. There are lots of, we'll be talking about the airway, which is the last lecture before we kind of disband. But it's really important. People tend to talk about sliding on both sides as a marker in a tube baby that the baby's tube should be in situ. Well, actually, if the baby is spontaneously breathing and it's in the esophagus, you'll still get sliding. But here, this baby is very well sedated. So it's a marker that this tube is okay. What profile?
it's B profile,
Very
and
good.
I would even like to keep scoring each of the area to
Okay,
like the predictive for BPD and all.
sure. Okay. Okay, so now you've got kind of R2 coming in there. What do we think? S-
In R2, we can see the batwing sign,
Yep,
and again the pleural sliding is there, but there is again disruption, discontinuity of the pleural line,
yeah,
and it's a B profile,
yeah.
and there is again subpleural consolidation.
Okay, great. Just quality of images for a 770 grammer.
Yeah, I think they're good. I think you can see what you need to see. I think they're good. Yeah.
Okay, can they be optimized?
Well, I guess you probably might be using a probe with that's probably a bit big for the baby because you can see lots of ribs on it. So like 3 would be ideal, but I
Yep,
guess you're in a situation where you're in a hurry.
yep. No, absolutely. And you're right. Using a hockey stick would be beneficial here. It will delineate the pleural margin much better. Naturally, the frequency that I'm using here is, I think, from our perspective, can be optimized a little bit more. My depth, I'm just losing out after 3 centimeters. For such a small baby, actually, you can go to 3 and it'll just give you a little bit better optimization. But for clinical interpretation, I think I would agree with you. This looks decent. Okay, so we're gonna go to R3, lateral. So what do we think over here?
Yeah, I
R3 was
think similar. Yeah, go
similar,
on ahead, Shazid. Sorry.
similar picture as R1 and R2.
Okay, great.
At one place, I can even see those are there linear bronchograms at that
The
fourth?
static bronchograms, I'm not convinced they're linear bronchograms. We'll see what linear bronchograms look like today. They're static bronchograms. For me, they're not linear. Subpleural consolidations. So any fractal sign?
Yeah, I can actually see it, the third intercostal space. maybe third
Okay.
and fourth, but they're very small kind.
Okay. We
Not,
sure that's a fractal sign?
I'm not very sure. I think
Hmm.
we need to see the superficial area more, decrease the depth and
Okay. So you can focus in. It's not a fractal sign. Take my word for it. Uh, okay. Now we're kind of going down to R4.
um, at the first intercostal space, I'm not sure if it is fractal sign, but definitely there is consolidation in the
I would
first and
agree. I
second.
would agree. Not convinced it's fractal sign. Doesn't have the irregularity, but you're right. So very similar kind of R1 to
Yeah.
R4. What about R5?
Oh yeah, so we can see a lot more here. There's a lot of consolidations with atelectasis and
Right.
probably they're linear bronchograms anyway.
Yep.
I'd probably call them static looking at the picture I'm looking at, but
So you're right. So lots of static air bronchograms. Just you're starting to see a few linear ones just at the bottom. So if I highlight them for you,
Yeah.
just those ones there, they're starting to look like they're in parallel. So I would agree. Surjit, are you happy with that interpretation?
Yeah. Oh, yeah, uh, there's white out lungs. At least in the previous pictures, I could see the acoustic shadow. But here it is more of white out lungs with more of atelectasis than R1, R2, R3, R4. It
Okay,
is increased. And
lovely.
what is this a superficial area? So, like, what is that in the
Uh,
muscles? Yeah,
over
like,
here,
yeah. What is
so
that?
at the moment, what I'd like to kind of say is it's not subcutaneous emphysema. It's
Okay,
probably just a little bit of muscle artifact.
okay.
So just to reassure you, yeah. But this is our 6 near the liver.
yeah, I guess this is your baby, they're supine and they've got collapse and consolidation posteriorly in their lungs, particularly inferiorly.
Yep. Yep. A- Anything else?
Extensive atelectasis,
Yeah.
uh, maybe linear
Yeah.
bronchograms.
So there are linear shadows over here, static air bronchograms that you can see quite extensive atelectasis on that right side. So, I mean, the back of the lung is really, really worrying because
Really bad.
it's not well recruited. Okay. You happy to make any changes on the ventilator?
I suppose just the one thing that's occurred to me there, they're on volume guarantee. So is there a large leak or is something changed about what's
Very
been
good.
delivered to the baby?
Nothing like that, but well done. I would completely endorse we need to do that. No leaks, nothing. So you're happy to go up on volume? You want to increase the PEEP based on this? Happy?
Yeah, I'd probably place them prone if the baby was able to do so.
Okay. Okay. Great. My only comment is, have we seen the left side?
No, not yet.
So we need a comprehensive scan,
Yeah.
quite crucially, because
Yeah.
the left side might have an air leak. Just being a little bit pedantic here to kind of say that always, if you're doing and planning any recruitment maneuvers, always do comprehensive scans. And I'll explain why. But let's have a look at the left side now. So for the left side, we're going to get two other people now. So I want two more volunteers. So workshop guys.
I can do alot Satish here.
Satish is there. Praveen, are you happy giving Satish a hand?
Yeah, sure, Alok.
So now you're looking at the left side of the lung. So yeah, just showing you our 6 more closely. Very big linear shadow there. Static air bronchograms. The gain setting here is perfect. This is the kind of gain setting that you want to get for the right side. You do not want it very bright. But let's assume that basically when you saw L1 to L4, it was very similar to R1 to R4. But what do you see here on the left back?
Well, it's total destruction of the pleural line. I can't see any pleural line.
Okay.
There's a bat wing sign.
Yep.
Obviously, lot more linear bronchograms. I wonder whether there's any dynamic air bronchograms. Probably not, I think.
Okay. Anything else?
Is there hepatization of the tissue-like
Yeah,
appearance?
yeah, there is. This is very much hepatized tissue, and there are varying degrees of hepatization, but you've kind of got. I think where Satish is slightly worried is, and I'm just going to highlight it here. So going by protocol, soft tissue, ribs, batwing sign. Now, just for everybody's knowledge, the view I'm using at the moment using a linear probe is what is called extended convex view. It just means that I can see virtually the whole of the back in one view, and it's available on the Sonosite. It's available on the GE. It's really good because really in an acute situation, I don't want to handle this baby too much by going into each individual space, taking two or three spaces at a time. So it just gives me a really good area of the geography. But with my batwing sign, I agree, Satish, there's absolutely no pleural line visible here. And really what we've got is this area of hepatization with a lot of static air bronchograms. This area here, this is not a dynamic air bronchogram. It just appears and disappears with inspiration, expiration. It's not moving in and out like a caterpillar. So this is still a static air bronchogram that you see. Now, anything else, Praveen?
Um, no, I think as Satish said, the plura appears to be, you can't see a plural line. There's a lot of subpleural consolidation, or rather, you can say it's very shredded,
Yeah.
like shred sign.
Yeah.
Can we say that it's a C line, the top?
Yeah, it's a C
Just below the
profile. It's a
yeah.
C profile. I wouldn't say there's a shred sign there, Praveen. It is and I think you've hit the nail on the head. It can be really challenging because these dark areas that you see over here, they really give you a really odd appearance. And to be honest, some of this is a combination of basically the acoustic shadow of the rib, and there's just quite significant atelectasis. Now, in the extended convex view, what happens is the acoustic shadow of the rib does not necessarily actually sometimes follow the rib, so it can be confusing. So a lot of what you're seeing here is atelectasis, no pleural line, with hepatization and just these dark areas and not really fractal signs. They're acoustic shadow of the rib. But what I'd like all of you to focus on is, can you see this area down here? So you've got these linear shadows that move in, which basically are like compact B lines. And these compact B lines basically give a kind of a sun ray appearance. So if this was the sun, these would be the rays of the sun. And this pattern is what it's called an S pattern. And S pattern, as I'll demonstrate to you in two very small studies done by Chioma et al., basically reflects a sign of recruitability. Now, what we know is that these horizontal kind of static air bronchograms tend to mainly be present with atelectasis as opposed to pure consolidation. And they may or may not reflect lung that's recruitable. Eventually, what will tell us whether this lung is recruitable or not is actually performing the recruitment maneuver. Any
So
questions about that?
so many
Yeah.
bronchograms, like
Sorry?
they're those vertical ones or like the linear
That's a
bronchograms.
linear
What do they
bronchogram
look?
there that you see. It's not very well, but when I'm just going to switch this off and show you the next image, L5, as you can see over here. Again, it's very, very homogeneous, symmetrical. So it would fit with atelectasis as opposed to pure consolidation. Lots of static air bronchograms, some linear air bronchograms coming in over here.
Okay, linear, these are the horizontal lines which we can
Yeah,
see.
just at the bottom here.
Yeah, right.
And this is really after recruitment by increasing the PEEP by 2 and giving the baby 30 minutes. It's the right side. And what you can see is we've recruited the lung much better. Now, I've used the right side in this particular situation because I did not want to handle the baby too much. and it was easier for me to access the right side. And really, for recruitment maneuvers, what is recommended in the literature is that you use the side of maximum atelectasis. But for me, accessing that place and putting the baby prone in this particular situation would have been a huge amount of handling. And the left side, based on all the equipment, everything that was kept there, was a little bit less accessible. So I've used the right side for a recruitment maneuver over here. Any questions so far? So just going back to our structured protocol, what we've done in this particular case is we've had a baby who's desaturating on the ventilator, deteriorating gases. We've gone, made sure that we've clinically done dope. We've prepared for the fact that we may well have a pneumothorax. We've kind of looked at all the clinical signs, transluminated. We've auscultated. We had reduced right-sided air entry, which is quite surprising because actually it's the left back that is more, I would say, atelectatic. But that just gives you the importance of the sensitivity of clinical signs, which can be quite confusing. What is really important is that after doing a lung ultrasound, which is comprehensive in this particular situation, we've identified atelectasis, we've made a management decision, and then really what we've done is we have reassessed. The most important thing is this baby clinically improved. So not only did we base our kind of management on the lung ultrasound alone, it's based on clinical correlation. So this baby's saturations improved. We were able to get this baby down to 60%. And really, once this baby was more stable, we went in for prone ventilation. We moved the baby prone, and really, this baby was much, much better by the morning, having been prone. Now, clearly, from our perspective, the important thing here, again, is you really want to make sure that this is atelectasis and this is not infection. So, once you've recruited, the question that some people then raise is, well, is that a fractal sign? Well, it's confusing. The key thing is I've clinically improved. Do I need to recruit more? And we actually did go up on the PEEP a little bit more in this situation, but didn't have any further improvements. So then came back down. And we kind of kept our PEEP at about 7 in this baby, 7.5, as opposed to kind of, I feel a little bit nervous using PEEPs above 8. I know that people use them 12 to 14 in some cases for acute recruitment maneuvers, and we'll talk about the danger of doing that. But clearly what you can see is a diffuse speckling in this region. So I have Dopplered it and I can't see any blood vessels there. Again, I'm going to say to you that we cultured and started this baby on antibiotics. In the region that we work, I think with the incidence of gram-negative sepsis, it is a no-brainer. I think you just cannot risk it, as well as with the medical legal consequences. But really, there are some babies where you might have recruitment and there may be signs of infection. So I'm just giving you an example here. So anybody want to have a go at describing this? So Anna? Anna Vaz?
Hi, Alok.
Hi. So just without the history, this is the left. It's basically L2.
Mm, This is a very bad one.
Yep.
I can't see the pleura, it's broken, and
Yep.
With lots of B-lines
Yep.
and consolidation. It's without the history, it's difficult to make thoughts, but it can be atelectasis or consolidation. I'm not sure about bronchograms. I think they are static.
Yep. I agree. So it's a really tricky one. Now, depending on clinical presentation over here, this was another desaturating baby where we tried a recruitment maneuver without any changes. I mean, this region remained as is, and really, it is a consolidation with an element of atelectasis. You have no pleural line that's visible over here, but it's not recruitable. And with the eye of faith, I can't see any S pattern with it. But when I put Doppler in it, I get a lot of blood vessels there. And really,
Yeah.
what I think is really whether this is a mnemonic kind of a consolidation at this particular point. Now, the reason I'm showing you this is there's a real risk that if you continue increasing the PEEP, you will make this baby worse. And the reason for that is, a PEEP can reduce venous return, it can impact cardiac output. And really, what is really important when you're doing a recruitment maneuver is that a recruitment maneuver is the interaction with the heart-lung unit. It is not lung alone. I think if you're not thinking of the heart in this process, then really you are asking for trouble. I've seen babies where we've had recruitment maneuvers of up to increases of PEEP of 4 to 6 over a period of time, extremely small babies, where often in those situations you cause not just air trapping, but the risk is you reduce venous return, and those babies often blood pressure starts dropping, and you just make BPH and pulmonary hypertension worse. So you have to be very careful when you're actually doing it. Now, classically, if an increase in PEEP to a certain point has not benefited, and you have this kind of picture, really you need to think about something else. Again, just the another picture of really what I'd say is focal atelectasis. In this is a different baby. This is technically the L2 region. You can see the spleen, but no blood vessels there. So this is not a fractal sign. This is focal atelectasis. Now the question is, when you look at this lung and you think of recruitment, there's not a lot of recruitment that can be done over here. But what you've got is you've got an AIS pattern. And the question from your perspective is this just interstitial edema, or is there an element of recruitment that will convert this B profile, which is technically AIS, into maybe well aerated lung? And in the acute phase, like if you have RDS in this particular situation, increasing volume guarantee and increasing volume might convert this into a complete A profile really within half an hour. And that is what we saw with scans that Surjit basically showed us in the last image. So really, when you're talking about recruitment maneuvers, we're not just talking about lung that might be atelectatic. We're also talking about the lung pattern, the lung profile, and whether we might be able to convert lung that has actually got a lot of interstitial fluid with alveolar edema into well aerated lung. And naturally, that depends on history. It depends really on the clinical course the baby is taking. But what I would say is when we talk about lung recruitment, and the next half an hour, we're going to talk a little bit about where the literature comes from, how we want to kind of use it in neonates, but more importantly, working on a structured protocol that's safe, that's described in the literature. Well, a lot of the work has really been done in adults, and there's a paper by Tuscan et al., which basically looks at use of lung to recruit, I would say, dependent areas of pulmonary collapse consolidation. Now, this has been very, very well used in the COVID era. We've had a lot of patients who have been helped with lung recruitment strategies, proning in particular, again, which allows recruitment of the posterior areas of the lung. And if you keep your baby supine, as you're kind of sometimes forced to do if you have umbilical lines, then a lot of these babies on the ventilator and just the posterior areas of the lung never get recruited. What is important when you're trying to recruit lungs is really it's increasing mean airway pressure by either increasing the pressure, the peak pressure, or the PEEP. But what is also important is that lung recruitment does not necessarily just mean ventilation strategy. It also means changing the baby's position. And I can't emphasize enough how, in some babies where I don't win, when they're on the oscillator, I will try prone oscillation with a higher map. And that just means I can recruit the posterior areas of the lung better. But really, this is just an example of an extremely preterm lamb being ventilated. And what you'll see is that as you increase the PEEP, it's going up. You can see recruitment of the more distal areas of the lung. So PEEP is just one mechanism, but it is probably one of the most effective mechanisms. If you're oscillating a baby, really, from our perspective, then what you'd be doing is you'd be increasing MAP. And how you do it and how fast you do it can actually have quite significant consequences on the heart. It can be very dangerous as well. I have seen babies developing pneumothoraces with recruitment maneuvers that are done too rapidly. Now, this is a PEEP that's going up by 5 every few seconds. And you can see how quickly the lung recruits, in particular the distal alveoli. The challenge is what you're not seeing is how venous return to the heart is actually deteriorating. Again, just another example of PEEP and recruitment. So PEEP of 5, now going up to a PEEP of 7, you'll see more alveoli open up, alveolar stability. So if you look at your lung ultrasound, and this is really important, and I'm just going to play this video again right from the beginning. At this stage, when you do your lung ultrasound, alveoli completely collapsed, so you will get no pleural line. There's no pleura established because you have no aerated alveoli. And that's why I'm showing you this video. So when you look at those images that I've just shown you of alveolar atelectasis, really the problem is here that you've got no pleura. This is all atelectatic lung. And there's certain patterns that are giving us information that this is atelectatic lung as opposed to just pure consolidation and pneumonia, which is why we're going to try a recruitment maneuver in this baby. On the other hand, in this baby, a recruitment maneuver might not work. Now, you can't see pleura here, but it's dominantly consolidation that's the problem. So really, that's why pattern recognition might be helpful. But more importantly, when you increase your PEEP, you recruit more alveoli, you'll then start to establish pleural line. And traditional adult models have kind of worked on increasing pressures quite rapidly. I would say by peeps of 1 to 2 every 30 seconds. And that's really good in adults whose heart, whose right and left ventricles will tolerate this without any problems. But in an extremely preterm baby, I would say even a 30-weeker who's 800 grams, if you start doing that very quickly, you start reducing venous return, especially if they have an element of pulmonary hypertension, you can actually end up making things worse. So the most important aspect of lung recruitment maneuvers when you're using them is clinical monitoring. And the reason I say clinical monitoring, not all of us use NAIRS. Not all of us have the ability to be able to, I would say, do heart-lung interaction, which is kind of doing simultaneous echoes to look at the right ventricle and the left ventricular function. And really what you'd be relying then on is clinical improvement. And clinical improvement will mean monitoring your saturations, monitoring your heart rate, monitoring the baby's pulses clinically, all of these parameters very, very closely. Because if your baby is clinically deteriorating, despite your recruitment maneuver, there are one or two possibilities. You might be decreasing venous return, but it's not unusual for babies to develop a pneumothorax in this process. And really, in that situation, you've just done a lung ultrasound. You might wait, and things can go very, very wrong. Again, this is just giving you an example of alveolar kind of recruitment. And really, what we're trying to achieve really depends on underlying pathology and the stage the baby is at clinically. Now, in a baby who's got RDS, who's got a B profile, who I've given surfactant, I might be trying to achieve well aerated lung. Now, that might be possible very quickly by increasing pressure, simply by alveolar recruitment. And I might not need to increase pressure or volume ventilation by a lot. I might do that by half a mil, 5 to 5.5, and repeat my ultrasound to see whether the lungs are aerated. And really, I might be able to achieve this recruitment quite quickly. On the other hand, this recruitment maneuver for a baby who has evolving stiff lungs with lung disease, like you see over here, might take time. And the question is, how quickly do I want to see this happen? And the question, and what I'd say is I don't have answers for this. It's individualized to each baby. But really, what is important is that you are monitoring your baby very closely while you're making any of these changes. Now, when you look at what you want to achieve, as I've said, this is a classical C profile with consolidation atelectasis. You know, your pleura is lost. Now, as you have incremental increases in PEEP, as you can see on the slide there, these kind of step ladder like movements, you can see recruitment of the lungs so that you've converted a C profile into a B profile. Now, when you use a protocol to do that, the adults classically described a protocol which has pretty much been duplicated in neonates. What they say is check lung aeration and look for evidence of lung collapse. I would say we're not just looking for evidence of lung collapse based on the baby. You know, if your baby has RDS and has a B profile, you might just be looking at moving a B profile to well aerated lung and an A profile. So you're looking at the profile before you are cautiously increasing whatever ventilation strategy you're using. I would not recommend increasing your PEEP by 2 or 4. I would recommend steps of 1 to 2 slowly. And what you're doing is you're making sure that your baby remains hemodynamically stable. Now, in adults, they use volume. So often in ARDS patients, they will increase preload by giving a volume bolus. Again, a lot of it depends on your underlying pathology. If it's an extreme 23-weeker who's just got a little bit of RDS, whose blood pressure is stable, I don't want to give him unnecessary boluses. If his mean blood pressure tolerates an increase in volume by 0.5 ml per kilo, really, do I want to start him on vasoactive drugs? So these might be unnecessary. On the other hand, in a baby with quite significant chronic lung disease, who's got really stiff lung, when I've had to jump up by PEEP of about 3 to 4, I may well need to support that right ventricle. If I've got underlying pulmonary hypertension, I might need, from my perspective, to recruit lung first, but it might be that I've achieved as much recruitment as I can, and this may be a baby who's got and needs nitric because actually I don't want to use more pressure. So again, lung recruitment strategies need to have heart-lung interaction analysis, but more importantly, clinical monitoring if you can't do that, and need to be done gradually in a structured way. And really, what that basically means is you are judging whether your patient is tolerating that maneuver of lung recruitment either by doing combined echocardiography, assessing right and left ventricular outflow, but more importantly, if you can't do that, really looking at clinical assessment. You need to make a judgment of whether your baby will tolerate that before you start. And that is where I would say extremely preterm babies need to be handled very carefully. Now, a simple example that I'll give you is a baby who is desaturating in 100% oxygen, who's had surfactant. Now, that baby may be desaturating because he's got pulmonary hypertension. And you might actually end up doing a lung ultrasound which shows well aerated lungs bilaterally. And I've just recently managed a 25-weeker with exactly this situation. Completely well aerated lungs with a significant pre and post ductal saturation difference. I've done an echo. The treatment there is not lung recruitment. This baby is on 5 mils per kilo. I've got good CO2 clearance. Actually, the risk is if I increase and try to recruit lung, I'll cause air trapping because this baby is already 9 posterior ribs on a chest x-ray. This problem is basically pulmonary hypertension. That baby needed nitric and showed a good response to it. So actually, that's a situation where doing a recruitment maneuver would have made my baby more unstable. So I've used heart-lung interaction to make my assessment, and actually that was against using a recruitment maneuver. Now, what we see when we perform assessment maneuvers is we may well be able to identify certain lung pathologies on ultrasound that give us an idea that this is recruitable lung. Now, classically, the adults have kind of described them as B or C profiles, very much in keeping with Daniel Lichtenstein's classification. But for neonates, we have done a little bit more work that's been done by a few more authors. I've already talked about how adults do this, but this is just an example of what I'm talking about. This is a C profile in an adult where they're just increasing the PEEP gradually with increments of 1 to 2 every 30 minutes. And really what you can see is gradually the C profile gets converted into a B profile with a very small amount of atelectasis. For neonates, I think the first paper that's identified the use of lung ultrasound in pulmonary recruitment is a piece of work that's been done by Piero and Chioma in Italy. It's basically Capetti's group, and they described a case series which basically looked at neonates with neonatal lung atelectasis and described a lung pattern which is called an S pattern. Now, really, before that, what we have to talk about is what we think is recruitable lung. Now, what I'd say is you can see different patterns of atelectasis over here. Now, if you look at slide A, what you can clearly see is a B profile. You can see atelectasis here with no pleural line with what is completely hepatized lung. A very similar pattern seen over here, but this is a little bit more geometrical. And then really what you can see in this image over here is atelectasis with what I'd call is these kind of linear horizontal air bronchograms. And this is a pattern that has been linked predominantly with atelectasis, really that might reflect recruitable lung. And this is work that's been done by Jing Liu and his colleagues. But all of these are basically classified as C pattern. And really, if you were to try and recruit these lungs, and you did that using the protocol that's been used by Chioma and Capetti, then a transition of this pattern into an S pattern that I'll show you really reflects effective lung recruitment. but more importantly, gives you an idea that this lung is recruitable and that recruitment maneuvers might continue to work in this particular situation. On the other hand, if you've used your recruitment maneuver and you've gone up by one, say, every few minutes, and really by the time you've kind of reached a peep of 8 or 10, you've still got this kind of situation. What you have to be really careful about is what is happening to the rest of the lung, because there's other areas of the lung that may well be uh, aerated, maybe with a B profile, which will undergo distension. And the risk is by focusing just on the atelectatic area, you might be causing problems in the other area of the lung, and you might cause that area of the lung to pop. And that's why the recognition of an S profile in itself uh, is important, but don't forget that you might have other areas of the lung that are being recruitment that were previously normal. So again, your clinical assessment during this period is very, very important. Now, how have Capelli and his group implemented their protocol? So they would do a comprehensive scan, noting the baby's position right at the start. So if the baby is supine, really what they're looking to see is areas of consolidation atelectasis and trying to look at the areas that are most maximally affected. They would look at those areas, identifying them, and then put their probe in the areas of maximum consolidation atelectasis in the most dependent position. So an example that I'll give you is if your baby is supine, the most dependent positions where you find atelectasis, as we've demonstrated in the ultrasound that we showed you earlier, was the right and the left lung base. Now, naturally, the left lung in that baby was more atelectatic, and probably from my perspective, that would be my point of interest. That is where I would keep the probe. But really, depending on your ventilation strategy, you would proceed with increases, and there are different ways to do it. Some people who use volume guarantee uh, would like to increase volume. I'm very fond of doing that where lungs are homogeneous. I just want to caution you about doing that in lungs that are not homogeneous. And a classical example that I'd like to give you is a right upper lobe or lobar consolidation, where you've just pulled the tube back. Now, the risk there is if your left lung is completely normal and you're using volume guarantee, is you might increase volume to recruit that right side, but actually the left lung being normal will need less pressure, but will eventually end up getting more pressure because with volume guarantee, it's really going to need more pressure to recruit the right lung. So inadvertently, you give the left lung uh, a, a lot higher pressure. And I've seen babies develop PIE in that normal lung quite quickly in situations like that. For me, what I'd say is a stepwise increment of PEEP, which is done very cautiously, is a better option. On the other hand, in the baby that we've just seen, where there's extensive atelectasis with quite uniform lung disease, uh, both on the right and on the left, I would my site of interest would be naturally the left, which was worse. But really, you could either go up on the volume, and I tend to use volume of 0.5 mils per kilo. In the protocol by Capetti, they increased the PEEP for babies who were on conventional ventilation with increments by 1 every 2 minutes, usually with increments tailored to about a maximum of 4 to 5. But if the baby was oscillated, they increased the MAP. And they monitored the baby hemodynamically, blood pressure, heart rate. And really, if those babies started desaturating, the blood pressure started dropping, despite this recruitment maneuver, then they would stop. And really, that was the protocol that was used in this study. What they realized is, and this is a simple example of where they've used increased, kind of pressure in this particular situation to recruit atelectatic lung is you get this appearance that I previously demonstrated of what look like these kind of sun ray appearance of the lungs. Now, these are because we're recruiting atelectatic lung, and they are because you're starting to open up the bronchioles and the alveoli. So you're kind of converting a C pattern into a B pattern with a compact kind of appearance. This sun ray appearance is what is classically described as the S pattern. And if you start seeing that, then really that is evidence that you are successfully recruiting lung and that this lung might be recruitable. On the other hand, if you kind of had an appearance like this after having done it for a while, and or your baby's starting to get worse, my advice would be that your lung-related recruitment strategy is not working. The question that you really need to ask is whether a position and if the baby is going to tolerate it, a physio-based approach might be better. So again, just an important example of how we're using clinical correlation in these circumstances. But really, this is clearly what atelectated lung looks like. Now, what do we think about recruitment in this particular situation? So I'm going to open it out to the group. It's a workshop. Commence. So,
The lung looks like this tissue-like pattern, and there are, I think, linear bronchograms,
great.
static
Okay.
bronchograms.
I'm going to ask Shruti. Shruti. What do we think? Can Shruti hear me?
Yeah.
What about, yeah, Shruti, what do we think?
So, yeah, I agree with Sujit. I can see the tissue-like pattern and pleura, like that continuity is.
Okay, let's stick to the protocol. Sure. This is where you're going wrong, both of you. And that's why it's so important you need to stick to the protocol. So what does the protocol for lung and ultrasound interpretation say?
Bat wing sign.
Okay, visible?
Oh, I can see the. But I can see like below the ribs, I can see the black area, which generally.
Very good. What
Pleural
is that?
effusion.
Very
Pleural
good.
effusion.
Okay, see, pleural effusion. So this is lung. Okay, that's parietal, that's visceral pleura. Now, do you want to describe the profile? Collapse, consolidation, atelectasis.
Collapse.
Okay, collapse atelectasis.
Yeah.
Why do you think that's the case?
So I think because of the pleural effusion.
Very good. Any other reasons by definition?
And also the borders, what area of the.
So
it's very geometrical. I agree. It's kind of, very geometrical. And then what else?
And if we put the Doppler.
Okay, we put Doppler on it. Nothing stood out. But what about these? What are these?
Yeah.
So they're linear air bronchograms. So that would favor atelectasis. Now, what do we think about a recruitment maneuver over here? So I'm going to go to Dr. Arif. Are you able to talk?
Hi, Alok. Yes, I am.
So what do we think about a recruitment? If I give you background and say that this is basically a preterm baby who is deteriorating with rising FiO2, rising CO2. This is the left lung. The rest of the lung is very homogeneous RDS-like, but on the left lung, we have this appearance.
Yeah. So, I believe this baby is vented, of course, right?
Yeah.
So, first of all, we need to make sure that DOPE protocol, we need to make sure the tube is in the right position.
Yeah.
And if it is so, then Alok, can you tell me what are the vent parameters at present, or we just?
So we're 24/6. We're in 80%. Conventional ventilation. Baby's sedated, paralyzed because we're not saturating. We've gone up to 100% now.
And how old is this baby?
So he's 12 days old.
12 days old. Okay.
Yeah. We've done a CRP. It's about 100.
Yeah. So for recruitment purposes, as we have the atelectasis, we need to optimize the VG to and um, the VG,
It's
sorry,
not
the
on
PEEP
VG,
can
it's
be
just pressure ventilated, 24/6.
only pressure ventilated.
Hmm.
Mm, I would say in that case, if the baby is pressure ventilated, um, and we should, I think, add the volume guarantee ventilation in this baby. So that much of preterm babies usually we do require them. The
So it's an option. The challenge
volume.
is actually you're kind of changing a parameter, so it might be difficult for you to kind of analyze, the volume guarantee might give you a pressure that's more or less than is required. So you'd need to know your tidal volumes. But let's say you just want to do a recruitment maneuver. How are you going to do it here?
Okay, recruitment maneuver in the baby.
Based
So
on what we've discussed.
yeah, in the 4/6, I would increase my pressures, the PEEP especially,
Hmm.
to recruit more of these alveoli.
Okay. Anything you want to know before that?
Now, mm,
So,
I mean, if there is any pneumothorax or no, we need to
very good. So you've
rule out
done
the
lobe,
pneumothorax as
it
well.
was
Yeah,
negative.
yeah. So yeah, it was negative. So
Okay, don't worry, I'm pushing you. So what I'd say is that what is really important is that you know what your baby's prior hemodynamic status is, pulses, blood pressure. So this baby was very septic, and we had quite a labile blood pressure. Now, this is just an example of a scan that I've given you from the net, from Jinglu's work. But if this baby clinically was very septic, then you had a low blood pressure, you'd
mhm,
have to be very cautious because technically an
exactly.
increase in pressure would decrease venous return.
Yeah,
But
definitely.
more importantly, why you also have to be very cautious is you've got a significant pleural effusion which is causing compressive atelectasis.
Yeah.
And if it's compressive atelectasis, really, this may or may not be a recruitable lung. So again, it's
Mhm,
having that thought process of going through that protocol that we're going to talk about. This is clearly lung that looks like atelectasis that might be recruitable based on this pattern, but it
yeah,
also has a significant effusion, and that
yeah,
significant effusion might cause problems with your ability to recruit that focal area of lung. It's quite focal as well. But the clinical condition of the baby, its blood pressure, its ability to tolerate the recruitment maneuver is quite important. Now,
mhm,
the different things that you could do in this situation, naturally, you could go up on PIP, you could go up on PEEP, you can increase eye time, you can oscillate this baby.
yeah,
Naturally, if you look at all those mechanisms, the effect on blood pressure will be more for certain things and less for something else.
yeah,
So a
sure.
lot of people in this situation, when they do the recruitment maneuver, would would maybe with a baby who's got low blood pressure try positioning first without doing the recruitment maneuver to try and see if it improves things. And
Mhm,
assuming that's the left lung with the whole of the lower lobe gone, you might just want to keep the baby left side up as opposed to doing the recruitment maneuver. So again, there are it's just holistically looking at your baby. But what is very important is that if you did a recruitment maneuver and you found that
mhm,
there was no correction in the pattern,
mhm,
as might be the case in this situation because you have a significant effusion, then really what you need to do is stop. Now, the problem in the literature, and the reason I'm taking you through this case is we just don't know how to define a lack of pattern correction based on how long we do the recruitment maneuver for, based on how much you increase the pressure for. There is just no good evidence. And I have
mhm,
seen people who are very aggressive, who go up in leaps and bounds, and I have seen some really bad outcomes with that. I've seen some bad pneumothoraces. I've seen babies collapse, become bradycardic, especially extremely preterm babies, because they're becoming more acidotic with reduced venous return. So
yeah,
really what I would say is what is quite crucial in those situations is because there's a lack of evidence, really everything is based on your clinical judgment, your ability to monitor this in real time very closely, but more
mhm,
importantly, the ability to do heart-lung interaction. Now,
So,
yeah,
Alok,
yeah,
one question. In this particular baby, if there is, I mean, if there is effusion, still this positioning, right, putting the left side up would help. In case of a collapse, when there is a part of a lung is collapsed due to secretions or whatsoever of blood, that helps in that condition.
yeah,
But
you're
in
right.
that
With a pleural
particular case,
effusion, it might not. But
it
my
might
key
not.
question is, I don't know that this is just compressive.
Yeah. Okay.
So I don't
Okay.
know if it's just compressive or not. The question is, I might still need to do a recruitment maneuver, but with a baby who might have very low blood pressure, that might not be the right thing.
Yeah.
So
And
it's,
would you
yeah,
consider tapping this baby, the
again,
effusion?
I'd look at, so we'll talk about this in the lecture Thursday after next, really
Okay.
how you determine which of these aspects, you might have atelectasis with a significant effusion. The question is, would you tap versus not? Again, the clinical profile of the baby is quite important. If it's high drops in delivery suite with massive pleural effusions, yes, absolutely.
Mm-hmm.
Because the risk there is, my lungs are completely atelectatic because of the severity of the effusion. Here, I mean, looking at that effusion, if that's what I see in the posterior space, I wouldn't. That's not a very large effusion. That's just
Yeah.
when I measure it comes out to be a centimeter. The bigger risk is if I try to tap that, I might actually puncture lung.
Yeah.
So
Definitely.
all of it
Yeah.
really depends on, again, it's a comprehensive lung ultrasound. I'd be doing every area, trying to come to mental modeling of what I think the primary problem is over here. The options remain postural drainage. The other option remains a recruitment maneuver. The third option, if it's a massive effusion, not that I can see in this particular picture, is whether you tap.
Mm.
And really, that's where I would say that recruitment maneuvers practiced in isolation, you really need to have holistic assessment. Clinical correlation is really, really important.
Okay.
In terms
Okay.
of protocols that are currently being used, I've if you go to your article library, there are 4 papers in it, and this is one of them. This is the Luster study. It's been done by the same group, by Maria Piero and colleagues. Now, really, what they have done is they have used a lung recruitment protocol, which basically looks at incremental increases again in PEEP by 1 every 2 minutes, or MAP by 1 to 2 every 2 minutes, really trying to look at the critical opening pressure, or what is called the COP. Now, what they have done is basically in babies, this is a piece of work that's been done as a randomized control trial, but really they've looked at recruitment conversion of the C to the S pattern, and then really a kind of an improvement to the point where you can achieve a B pattern. And really, once you've achieved the C to B pattern, that is really your critical opening pressure. But you can see that, and when you look at this paper, there were significant increases in MAP in a very short period of time. But eventually, what they do is they then allow the lung to de-recruit and go to an opening pressure that is not as high as that, because naturally they're worried about the risk of what this might be doing to areas of the lung that are recruited. They might be becoming overdistended. And by actually coming to a middle ground, what they were able to demonstrate is, a middle ground of being able to achieve what I would say is satisfactory lung recruitment over a period of minutes. Now, translated into clinical practice, we have to be extremely careful because there are side effects to this. Well, we risk a pneumothorax with volume guarantee. If it's done for an extended period of time, just remember, if you have asymmetrical lung disease, you have a right-sided collapse with a left lung that looks predominantly normal, or you've got really RDS because you've got surfactant that's gone down the right main bronchus so that the right lung is better compliant than the left lung. You risk volutrauma and PIE. Uh, for lungs, you risk air trapping of the normal lung that's been kind of already well recruited, but the hemodynamic status can be significantly kind of affected. So really, there are at least 2 other pieces of work. There's a piece of work that's been done by Francesco's group in Italy, again. And really, what they've done is instead of using the pattern-based kind of change, they've used lung ultrasound scores. Now, again, the criticism for that is that might not be valid where you've technically got, I would say, a C profile. So what you've got to kind of then do is develop your own clinical judgment of how you're going to implement this in practice, because with just two studies and a very small number of kids, babies in particular, who've been recruited to these studies, there is a lack of high quality evidence that implementing this practice, gung ho, to try and recruit areas of lung, to try and improve oxygenation, as has been described with clinical lung opening strategies, is completely safe. I think you need to be very, very cautious. Now, a simple example that I'm going to give you is this baby where we did a lung recruitment maneuver. Now, really, what we've done is we've increased the PEEP by 1 to 2 with very marginal recruitment of the lung, but without actually any change in the lung profile. And really, the challenge that I faced in this baby, extremely preterm baby with significant RDS, who has what is basically an AIS pattern with an area of atelectasis. Really, that's a very small area of lung to be recruited. I've gone up by the PEEP by 2. It's not actually improved my pattern. Uh, what it has done is marginally improve my oxygenation in this particular situation. Now, the risk of increasing PEEP too much is I don't have much lung to recruit, but then the risk is I might actually cause a host of these problems that we've just discussed in terms of side effects, which might actually make this baby's condition worse. So again, a recruitment strategy has got to be done very cautiously, because actually what you can see is if you look at this particular area, if anything, my static air bronchograms have actually increased. And while I've been able to recruit this, the actual pattern of lung hasn't changed. How would I implement this in practice? Really, what I would say is that if I've got a situation, a clinical situation where I have a baby who's desaturating, I would go back to the background clinical presentation of the baby. I would think about excluding dope, considering whether my ET tube might be low. So anything that's reversible that might actually allow this baby to get better. But more importantly, what is really important is making sure that my ET is not down the right main bronchus. I would then perform a comprehensive lung ultrasound to make sure that I don't have a pneumothorax and try and identify whether there is an element or a pattern of lung that allows me in this particular case to be able to recruit lungs safely. If that was the case, I would follow a structured protocol. And that structured protocol, basically, from my perspective, is making sure that I have identified the area that I consider would be the best area for doing a recruitment maneuver, that this baby is clinically stable enough to be able to tolerate this maneuver. He's hemodynamically stable. Uh, I would then, in that situation, put my lung ultrasound. I like using a linear probe with extended convex imaging because it just gives me a much larger footprint. It's much better. It's less handling. I don't, if I'm using the hockey stick and I can only see two spaces, it's really giving me much less idea. But more importantly, if the baby is supine, why not give this baby the best possible option? If he can tolerate it, I'd pop him prone and I would actually go into that area, keep my probe there, and really start working with. My tendency is if they're not on volume guarantee and they're conventionally ventilated is to increase the PEEP. And I usually do it by 1 every 2 minutes to a maximum of 3. If I do not get an increase or an improvement in my pattern or an S pattern within a period of 30 to 60 minutes, I would consider alternative ways of trying to see if I can open that area up, which would be postural drainage, physio if the baby can tolerate it. Uh, I don't feel brave enough to go up by more. I might consider changing my method of ventilation, oscillating this baby, naturally because diffusion and lung recruitment will be benefited by mechanisms beyond conventional ventilation. If I'm oscillated, I'd go up by MAPS by increments of 1, again, in a very similar manner, maybe by a max of about 4. Again, keeping a very close eye on the baby. If the baby's blood pressure starts dropping, the options then are whether you stop or whether you need to consider supporting the right ventricle in particular. You increase the preload with a little bit of volume if the baby's going to tolerate it based on the baby's condition. But this is really the protocol, and I'll share this with you. And I call this the DPSS, basically detect, place, start, stop. It gives me a clear structured approach to how I'm going to do a recruitment maneuver, and it needs to be done very, very cautiously. But more importantly, while I'm doing it, what I am doing is clinically correlating. I think if and where I'm in a situation where I've got colleagues who might not be doing lung ultrasound, a chest X-ray is really, really important, preferably before and after. But you only do the recruitment maneuver if the baby's improving. You continue it while the baby's stable. And more importantly, just be aware that these are babies who can pop. And if they are popped, please be aware that you might need to reassess them very quickly, very, very soon. Just a lack of improvement should not mean that your recruitment maneuver is not working. It might also mean that you've developed pneumothorax. It might be that you've got pneumonia or a consolidation that's not recruitable, and you need to consider, the alternatives. That really is the talk. Now, I'm going to share the papers with you, all 4 of them. Have a good read of them. But really, when we do peer review next Thursday, I will be giving you cases, lots of different cases, where you'll be basically interacting with the cases, making your decisions in real time, and we'll talk about them and see, what happened to the babies after you've made those decisions. Any questions?
Dr. Alok, what
Yeah.
is extended convex view? Like, how do we, like, we
I'll
get
show you
more
next
number of
Thursday. I'll show you next Thursday. When I'm on the
do we-
unit tomorrow, I will take a picture of how it looks. But really what it does is it gives you a very large footprint. And the advantage with it is it can be done with a linear probe. So a good example is this is normal, but really when I go to the back here, I'm using extended view, which is giving me 1, 2, 3, 4, 5, 6, 7. I mean, in a small baby, I can see the whole lung. So I can
No, but how
basically
do we
see.
go for
So,
sonocyte machine? Is there
sorry.
any like is there any knob to change it in my sonocyte
So
machine?
if you can send me a picture, so the best way to do it is when you go into your knobs, you've selected your frequency and your preset. If you press the frequency again, then really what it should be able to do is give you an extended view with that frequency. Uh, the best way to do it would be for us to have a kind of what I'd call is a bottom call so that I can have a look at your machine with you while you're doing the scan.
3 options when we click a lung ultrasound, like penetration, resolution, and general. These are the 3 options.
It won't be under penetration resolution. It'll probably be under general. But I can show you, for all of you using a GE, I will show you how to do it on the GE.
Okay.
Any other questions? I'm just curious, how many of you have used lung ultrasound recruitment maneuvers? Clinical lung ultrasound recruitment maneuvers? Anybody? I know that Dr.
Yes.
Ashraf has. Yeah.
Clinically, we have done, but with the lung ultrasound, like, no.
I think the benefit of using lung ultrasound is the objectivity. The problem with just clinically kind of relying on, so a clinical kind of recruitment maneuver is done in different ways. Some people, if you're not saturating, will put the baby into an FiO2 of 100% and keep rapidly increasing pressure with beeps every 30 seconds and kind of go up by 6 or it's massive. You sometimes go from 6 to 12, and really what you're starting to see is when the baby starts saturating and pulling down, and it's really bad outcomes with that. So I've seen babies who recruit as well. The advantage of using lung ultrasound is you can actually see recruitment in real time. The challenge is, just remember, you're looking at the area of lung that is de-recruited, that is atelectatic, that is potentially recruitable. What you're not looking at is the area of lung that is normal and seeing what happens to that. And that is the detriment here, is fixation error. You can get heavily fixated and babies can deteriorate very quickly. So just be very careful. Dr. Ashraf, what's your experience?
Yes, Dr. Alok. يعني really يعني maximum I reach to be to 9. If I reach to
Yeah,
9, just be cautious. Maybe after 15 to 15 minutes, I will go back to make it and reduce to 7.5 or 8.
yeah, I agree. I think being
Yeah.
conservative, and look, I know that colleagues in America who, they call me peep phobic is the word that is used for people like me. And I just say caution, cautious approach is better in situations like this. But more importantly, the bigger problem is if you end up with a pneumothorax, then you're in deep trouble. Any other
Yes, I mean
thoughts? Yeah.
I mean should be like this, should be serial follow up, يعني in
Yep.
short time to be safe. Yeah.
Yeah. Now the challenge again is holding the probe there for 10 minutes. That's a long, long time. Sometimes the nurses kind of think you're crazy. What are you doing? And especially in the UK, where nurses will kind of wonder what the hell is happening, it's worth just explaining to them before you start, the length and the time you're going to take to actually do this. But more importantly, just be aware that somebody's keeping an eye on the baby hemodynamically, SATs, heart rate, all of those things. Because while you're doing the scan and looking at the actual image, nobody's keeping an eye on those observations. Uh, Okay, I am really grateful, guys. We have a lot of, I would say, scans that we're going to discuss, a lot of interaction the coming Thursday as well. And the next therapeutic intervention that we'll be discussing will be tapping pneumothorax and pleural effusion using lung ultrasound. So that's something that'll come up. Some of you have asked about wanting to know more about uh, Key's space and Avicine's space and the science related to pneumothorax. I've made a new video for you, which I will share with you tomorrow, which basically looks at that in great detail. But I will show you a case on Thursday to describe it in more detail so that you've got an idea of what those signs are and why they might be important. Thank you, everyone. I'm grateful for your time. God bless you all.
Thank you, Alok.
Thank you.
Thank you, Alok. Thank you, Alok. Bye bye.
Thanks, Alok. Bye-bye.